So hello everyone. Today we're gonna start the meeting, and Dr. Hassan will lead the meeting, and then we have the green team will present. Thank you everyone. Dr. Hassan, it's yours.
Thank you, Dr. Nader. Hi everyone. Today our agenda will start by Dr. Sulafa. She's going to present the SPSS. Am I right, Sulafa?
Yeah, I'm ready. Thank you, Dr. Hassan. Thank you, Dr. Nader. Hello, everyone. I would like to start presentation on SPSS. So I will share my screen. Can you see my screen? Okay, so this is the SPSS, and you can for sure buy it from IBM. You can have 1 month free, and then you can I want to move this bar. Yes. So you can have the 1 month free trial, and after that extend by buying monthly fee. So we have this screen, which is called data view, and we have variable view. Both look similar when they are empty, but when you start entering your data, it will look different. So you can add your data either manually, or you can import it if you have it is ready. XLX, like you have your data in XLX or XLS or XLXS, and also if you have comma delimited file CVS, you can also import it. Text and any other database system you can import here with some manipulation. So I will give you a small summary about how to enter the data manually, and then I will show you example if you will import it from your computer. So first, be familiar with this screen. The first one, the data view. So you will enter your variable. So the first variable, for example, if we have the ID, we can enter 1 for the first observation, 2 for the next, 3, 4. So we have, like in this research, 4 participants or 4 observations. So the first observation here is called 1. If you add in these rows, you add more participants, for example, for the research or more observation. And if you add here, you add the variable. So the column for the variable and the row for the observations. So you will add, and automatically SPSS will provide the name like var 0001. And here, if you enter, like for example, gender, so we can code it 1 for female and 2 for male, or 1, 2 for this participant. So also SPSS will automatically name this variable when var 0002. If you would like to change this name for this variable, simply you can go to variable view and you can rename it from there. Okay, so for example, the first variable, we can rename it as ID. And SPSS has special rules for name your variable. So you can put any special character in the middle, but you should start with alphabetic letter, and you cannot put a space. So for variable, you won't like to, like blood pressure, you have 2 separate words, and you want to name your variable blood pressure. You have two options to do. The first option to do underscore. The second option, you can label your variable here from the label. So if now I want to write ID and I put a space like ID and go for this, SPSS will give us this notification like your variable name contain an illegal character, so you should change it. And automatically it will return the variable name to the default. So we can write here ID, and if you see, automatically he will see he will write the type for this observation or this variable. So it's numeric, but you can change that. As we know, ID is not actually a numeric or continuous variable. ID is to label a person or a subject with a number for labeling, not for it is a continuous or numeric variable that we can add or we can subtract. So if our ID, for example, here 1, 2, 3, 4, we cannot add them or subtract them or multiply them, because here we use it as a character or a string, not as a numeric. So what you can do here, simply you can change to string. So when you put it as a string, it will be now like SPSS. No, this is a character, not a numerical variable. So what happened, if you notice here now, the ID is left justified, not right justified like our second variable, because the character variable will be displayed left justified, and numeric variable will be displayed right justified. So if I didn't put this variable and I come to the screen and I take a look, I will know this ID is actually character or name or anything, and I will know the variable 2 is numeric, and I can do my manipulation here, subtract or addition or anything. The second thing also I can do is go to the variable view, and here, when we look to the type, we can also see if it is a character or numeric variable. So now we change the type of the variable, and here it is, this variable is gender, so let's rename it as gender. And gender, we can also change it as a string because we know it's either male or female, but unfortunately, like SPSS, if we don't want to make some statistical calculation, prefer to use the numeric coding. So for gender, I would just leave it as it is, but I can know the gender here by labeling the value, and I will come later to that. So here the whites, you see also SPSS put it automatically, and the decimal space also it show you. So for the decimal space, we can change the decimal. So the whites, for example, if we have 5 numerical variable with 5 character, like 5 numbers. So you can decide how many decimal you want, or how many number after the decimal you want. So here in the gender, because I didn't change it to string, we can play around. So if I add some variable, like the number in the decimal and go to see what happened, you can see now after the 1 or the 2, which SPSS think this is the number, he add 40 because you told them, hey, SPSS, I need 4 decimal after, I need 4 numbers after the decimal. So you can manipulate here, you can work sometime, you have number which is important, you don't want to just round it. You can just come here to the decimal and say you want 4 number after the decimal, or if it no big difference, you can just add 1, and you can see here just 1 0, or just you can put it like 0 and no decimal will be shown up. No decimal will be there. So now we came to the label. As I mentioned before, sometimes you want a full labeling to a variable name. Like ID, you can put driver license. For gender, you can put male or female. So you can put here anything without rules, like you can put a space in the middle. So embedded space is correctly written by SPSS. So you can put anything here. For example, gender, I can say male and female. So SPSS can read this correctly. Also, sometime for the value, you want to show what is the category for your value. For example, if we come to the gender, I can add from here what when mean and what to mean. So I can add value of when. If SPSS encounter number 1, he will write male, and then if he encounter number 2, he will write he will read it as female. And then just we will press OK. And when we go to the data view, it still will be the code 1 and 2. Oh, sorry. You can change from here. So it's still there, the code 1 and 2. But if you look at this icon, the value label, it will change you for male and female. Then we can add another variable. So we can add, if for example, this is data about COVID-19 hospital admission during last month. So we have the ID of the patient, which can be the medical record or any ID, and then we have his or her gender, and then we can put like BMI. So for example, for this guy, his BMI is 24. Don't judge me, I will put different category for the BMI. So we have 24, 29, 34, and 39. And then we can go to make these codes like category for our BMI. So we want to compare normal weight with overweight or with obesity type 1, 2. So just we'll come here and we'll tell SPSS, like put the value of 24 is normal, and put value 29 as obesity type 2. We can add also 34, sorry, here overweight. And here we can write obesity type 1. And then we can write also 39 as obesity type 2. And here we made like category for everywhere of every weight we have in our data set. Actually, this is simple, but we can put the range, which is better because we will not have all the time of our variable as 24, 29. We have range with decimal and so on. So now when you look at our variable 3, you will see that we have all category of the weight of the BMI here. And we can rename also the variable as BMI. So we can add also continuous variable here. So now we have ID, which is character, and we have gender, which is binary, like male, female, two variable, male and female. We have our BMI, which is categorical. We can write, for example, their temperature. We can write it as continuous variable. So we have patient with 39 degree, we have patient with 38, and this without fever, like 37.1, and this with also fever, 39.5. And we can look at our variable as continuously with decimal, and we can change it, as I mentioned before, how many decimal do you want? So they put for the temperature 2 decimal after the 2 numbers after the decimal, and we can just rename our variable as temperature. So sometimes we can have missing variable, like the front desk didn't write the missed value for 5. So I come here and put the ID number 6, and I put the gender, I put the BMI, and I put the temperature. And you see the 5th participant is not there. I didn't put the numbers or the observation for him. So what SPSS will do, he will put blank for every character variable, like it will be empty, and it will put dots for or periods for every value which is numeric. So if we go to variable view, we can see the gender, BMI, and temperature for SPSS. It's right justified and it's numeric. So automatically for this variable, he will be dots. But for this observation, which is ID, is the character, so he will leave it as blank. So when you come to take a look, you will see very obviously you have 3 numeric value missing and 1 character variable or string variable missing too. So just also the measurement, you can put, like for the BMI, you can tell SPSS that this is like ordinal. We can just put into order: normal, overweight, obesity type 1, obesity type 2. So, or scale, like for example, the temperature here, it's continuous variable. I can tell SPSS this is like scale, and so on. So you can manipulate here in the variable view, you can manipulate your data, and you can tell SPSS what it is dealing with. Also, you can put like address, for example, the address of the patient. So we can tell Denver, like D underscore, I want to tell the state, Colorado, then Aurora, Colorado. And I can write here like Austin, Texas. I will do a little bit different from that one. Austin, Texas. So don't judge me on that. I don't know the codes for the Texas. So just we'll write it here also, the city for all the observation, Denver, Colorado, Colorado. And here also Denver, Colorado. And SAS will know that, like, SPSS, you can rename here like city and label here as city state. So everyone will come to take a look. He will know this is the city and state. Also, we can add phone number here. So 72. So the participant phone number also, you can add it here, and some will be missing. and just you see like this is very long number. Sometimes SPSS can write E17 if you write 17-0. So, and here just it's numeric, but if you want to change, as I mentioned before, you can change it to string. And here also, sometimes you need in your variable to add comma, like you want to be in thousands, hundreds, and then you can add comma. You can add dollar if you are writing some like value of a price of anything. You can also change this, or also you can tell SPSS that this is a date, and what format you want your date. Do you want your date to be day, month, and years, or as here in US you want it month, day, and year, or you want just the year and day? So you have many formats here you can use to tell SPSS what is the value of your value. So here I can make comma, for example, to show my number. It's actually just a phone number, but it's appear here by comma. And we can change this to phone number. So this is summarize how you can enter your data manually in SPSS. And now I can show you how to import your data, and very simple basic statistic procedure that you can do. Is there any question in the chat, Dr. Hassan? Okay, okay, no question. So please feel free to unmute yourself and ask Dr. Nader if you have any question. Because still I'm not familiar with SPSS, so. Okay, so now I will close the window and try to import the data from my computer. Okay. I'm sorry, it is a little bit slow. I'm so sorry, there is lag in opening the SPSS again. I will close the camera. Sometimes it helps to speed the download, just a moment. I'm sorry for that. Now I will share my screen. Can you see my screen now?
Yes.
Yes, we can.
Okay, thank you. So when I mentioned before how we can enter the data manually. Now I will show you if you have already data in your desktop and you want to import, you can go here in this icon and press to open the data document, and just you will specify what type of file do you have, like if you have Excel sheet, or if you have comma delimited, or you have text, or you have SAS or Stata, any type of database management system, you can import here. So I will import now Excel. So I have like this report, laboratory lab report, I can open from here. So you just click on the type of file and then click your file and you can open it easily. So it takes time to import, but usually just few seconds to import it into the system. I can try another one. Just it paused, sorry for that. Yes, it comes. So it will come with you this window, read Excel file. You can specify the variable name if you have like headers in your Excel sheet. So you had the header, for example, the same COVID test, COVID data. So you have ID and you have your gender and BMI, phone number, and all that variable. You will tell SPSS that read names from the first row, and then it will be there like it comes here. Then also you will specify it, and when you hit OK, all the data now the server go out. It's okay, just you know the idea now. Yeah, it comes here. So it will show, it will pop up here. Your, for example, this Excel sheet had subject ID, lab date, lab test, lab value, and units, and the ID like 101. So all these observation for same person, and then this observation for the second person, and this the first person come again on July 13. So you can read your data from here, and you can also sorry.
Excuse me, where's this data? Because here in your share screen, I don't see anything, just the main page of the SPSS.
Okay, sorry, I will share again.
Okay, thank you.
Sure, thank you, actually. Can you see it now?
Yes, the data, yeah. And actually, I missed the whole, then because it was freeze or something.
Yeah.
I didn't see how did you import it. So just you go to import new data. If you can, if you can just repeat this again, this point.
Sure.
That would be very helpful of you.
Sure, thank you, Hiba. So you go here to this icon and you will open it. And here you can specify your file type. So if XLX, just you will change from here to XLX. And it will pop up. Automatically, it will bring all your XLX sheet in SAS. So if I change it, like for, I have some CVS also, it bring your CSV file, and you can change also to text like that or anything, and all my file in my laptop appear here to me, so I can choose which one I want to make the analysis and just open it here, like for example this one, and open and run. this needs some manipulation, not like Excel. Excel is very easy, just you will run it immediately. And we run the Excel one, and this data appear for me here.
Thank you very much.
Sure, sure. So maybe I will do our presentation on basic statistics because now my time almost gone. Do you have any question?
I think there is no question in the chat, but please feel free if you do have any question, ask us. Hiba, I think she has a question.
Yeah. Is this gonna have a continuation for data analysis, or just we just for the data entry? That's my question.
Yeah, just I would like we can make a small presentation about how to calculate the mean and median and mode, but because of the time, maybe we'll do another presentation on that.
Thank you.
Yeah, and if
thank you, Sulafa, for this. I'm just in general, and I'm curious to see, like, if it's like part of the agenda we're gonna go through analysis, like multiple linear regression, or just we will keep it that level of data entry.
Yeah, I would love
That's my
to.
question. Yeah, for the other group next, maybe.
Yeah, for multiple linear regression, I'm not prepared for now, but we can do another day. But for today, just I prepare for mean and mode and confidence interval for that. But if we have time by the end of the lecture, I can present it.
No, not you. Okay, thank you.
Thank you.
In general, maybe this is the agenda for today, is to have the data entry and these only topic. I'm just asking for the future. Is there is any? That's my question in general.
Okay, sure. We'll ask Dr. Nader about that. Thank you, Hiba.
Thank you so much, Sulafa. Such a wonderful presentation. I believe everyone has enjoyed it.
Thank you so much.
So now maybe we can move to the second agenda because we're already under the time pressure. So the second agenda will be delirium. So just give me a second. I'll try to share my file. Can you see my screen now?
Yes, we can see.
Perfect.
Yeah.
So my topic will be simply about the delirium. Such a good topic. I think we can go over it. So I'll be covering what is delirium, how we can recognize and diagnose delirium, what are the predisposing factor and what are the risk factor regarding delirium, how to evaluate and treat delirium.
Dr. Hassan, we have a view of your files, not the actual presentation.
Sorry.
Yes, thank you.
Perfect. Lovely. Thank you, Dr. Nader. So And the topic will cover also a little bit about the epidemiology, the incidence and morbidity, recognition and diagnosis. And the most, I think, interesting thing about the pathophysiology in that manner, and maybe a little bit about the evaluation, management, and prevention. Please feel free to ask any question throughout the presentation. I believe delirium is way more clear than many other terms when it comes to the confusion. So, for example, it's way more clearer than the idea of encephalopathy and those kind of medical terms. So, simply we can define delirium as acute confusion state, acute mental change, altered mental status, organic brain syndrome. All of those terms might be applied when it comes to the definition of delirium. Keep in your mind, we always keep the word acute. So it's something of a short term and it's affecting the brain. So incidence of delirium, you wouldn't be amazed if I said 1/3 of all the patients presenting to AD, to ED or A&E here at the situation in Ireland, so will be delirium. 1/3 of inpatients age 70 plus on general medical unit have of whom are delirious on admission. In fact, actually, there is a recent kind of research is suggesting nearly 20% of the patient in the medical ward might develop delirium. And the number is much, much larger when it comes to the cardiac ICU. It reaches up to 60 to 80%. Sometimes I believe this is more than the reality, but certainly if any person worked in the ICU setting, we could say the number is not very far from the reality. And unfortunately, it might reach up to 90% in the end stage kind of care. So the number is huge. And still, when I come to the manner of diagnosis, we all will say that's maybe it's underrated and the diagnosis is really below the kind of reality. So morbidity associated with delirium is 10-fold risk of death in hospital, 3 to 5-fold increase in nosocomial complication, prolonged stay, post-acute nursing home placement, poor functional recovery and increased risk of death up to 2 years following discharge. Persistence of delirium will lead to poor long outcomes, unfortunately. And that's the thing I was just a minute ago talking about. So only 20% recognized by a doctor, in fact, less than 20%. And nearly 50% or maybe less than that recognized by the nurses. So we're still not, I think, meeting the target or the reality when it comes to the diagnosis. And I believe we agree with these kind of things because it's confusing when it comes to the diagnosis of delirium. So there is two diagnostic settings we can follow, either DSM-5 or confusion assessment method. DSM-5, and I'll explain it just in a minute. DSM-5 is precise, but it's very difficult to apply. And confusion assessment method is definitely very useful, and the sensitivity and specificity is more than 95%. So there is no much difference between, by the way, between DSM-4 and 5, except in one part, and I'll come over it. So there is 5 criteria in order to diagnose the delirium based on DSM-5. So first, disturbance of consciousness with reduced ability to focus, sustain, or shift attention. So the easiest way, if you want to think about this criteria, when you ask the patient, it's very clear that he's not able to answer the question in the manner you would expect, and it's very difficult for the patient to move from one topic to another. So that's how you could recognize there is a disturbance in the consciousness. The second thing, change in the cognition. So you might see that there is some kind of memory problem, disorientation to the time, to the place, to the people. And the third one, and that's very, very important to make the diagnosis of delirium, it's developed over a short period of time. And by that we mean hours to days. And I'll skip this one, I'll go to the last one. There is an evidence of, so that you do have an evidence from the history, physical examination, lab disturbance. So you do have some kind of evidence. Don't forget the medical condition, and as Dr. Nader said, the drugs or the medication. So DSM-5 has only added this one, number 4, disturbance are not better explained by another pre-existing or evolving or established neurocognitive disorder. So you are talking here about a new thing, and it's not severe. So the person is not severely, the conscious of the person is not severely reduced to the level of coma. So you still the person in pre-coma stage. So just 5 things you can follow maybe to make the diagnosis based on DSM-5. So confusion assessment method, it's easy, it's sensitive, it is specific. So you might think about acute change in the mental status and fluctuation cause, inattention, disorganized thinking, and altered level of consciousness. So you require 1 and 2 and either 3 or 4 in order to make the diagnosis based on the confusion assessment method. When it comes to the spectrum of delirium, we mainly have 3 kind of things. So it's either hypoactive delirium. In that case, you will see the patient is sluggish, less active. This is by far the most common form of delirium, and unfortunately, it has the poorer prognosis. Or in 25%, the hyperactive, agitated kind of delirium, or it can be mixed. Regarding the pathophysiology, it's really a kind of, as I said, it's interesting, but it's not well understood. So by far, maybe we've heard a lot about the cholinergic kind of involvement. So I'm here talking about the acetylcholine. So the kind of anticholinergic, or let's say maybe cholinergic inhibition will be involved, and on the same manner increase the activity of the cholinergic receptor, or let's say maybe the kind of increase the activity of the acetylcholine in general will be also involved. So that's mean in the manner, for example, of the medication that's increase or decrease the activity of the acetylcholine, might contribute to the delirium. And that's not the only theory or not the only explanation. There is many things might contribute to delirium. For example, GABA activity. You might not be surprised if I said with the same way of explaining the cholinergic activity, the thing that might increase the activity of GABA, I would say, for example, the hepatic failure or maybe benzodiazepine might contribute to delirium, and reduce GABA activity might also contribute to delirium. For example, with alcohol withdrawal or benzodiazepine withdrawal. So two things might contribute to delirium in the same time. Not to forget to mention also the idea of inflammation. We understand many of the cytokines might be involved in delirium. For example, increase the activity of C-reactive protein, interleukins, and those kind of mediators. So when it comes to the predisposing and precipitating factor, it's always a good idea to dig deeper in the history and think in a wide manner what could be the reason, make the person at risk, or trigger the problem to start. So, for example, some of the predisposing factors, advanced age, dementia. This is, I could say, this is one of the most important risk factor or predisposing factor. And unfortunately, there is always a coexistence between dementia and delirium. So dementia might be a risk factor for delirium, and delirium might increase the development, or unfortunately increase or make the prognosis of dementia, or the development, in fact, of dementia much worse. So, and that's why the diagnosis is usually challenging. So you wouldn't be sure unless you took some of the family member, some of the people who know the person in a good manner than you. This acute thing, or this is an ongoing thing. But to be safe, try to identify or try to deal with anything that could be new, that could be dementia. Some other of the risk factor, like functional impairment of the daily activity, medical comorbidity, history of alcohol, male sex, and sensory impairment. Keep in your mind, when it comes to the management and prevention of dementia, we always try to tackle those kind of things. So one of the things that you could use in the management, if the person has lost his A rate, you could provide him with his A rate. Those are very vital in the management. And precipitating factor, or the triggering factor. So those are the things that make the problem start. Infection, by far, this is one of the most important precipitating factor. Medication, as we just a minute ago talked about the cholinergic activity, the GABA activity, and those kind of medication, you should always think about those. Not to mention the severe anemia, uncontrolled pain, urinary retention. So all of those things, you could think about them in the manner of the other medical problem, the medication. So they are by far, those are the main group considered to be a risk, a precipitating or a triggering factor. So regarding the history and the physical examination, focus on the time course of cognitive changes, especially their association with other symptoms or events. Medication review, this is one of the vital things. As Dr. Nadir usually said, try to review the medication. That could be one of the reasons behind the problem. Physical examination is not different than any kind of standard physical examination we do. We will start by the vital signs, the oxygen saturation, and those kind of things. But here we might pay special attention to the neurological and mental state examination. So the laboratory test, definitely after we did a bit of a history and a physical examination, we will start by the kind of general panel, like the CBC and electrolyte, liver function test, and renal function test, because those are of a significant importance in this kind of medical problem. Just maybe I can remind you, for example, the benzodiazepine and GABA related activity. It's always correlated with the state of the liver, because the metabolism is mainly rely on the health or the kind of activity of the liver. We can only do the the kind of imaging study if we are thinking that the reason could be a trauma or a new, or you observe a new focal neurological finding. EEG and CSF rarely helpful, except if the person is having seizure or a sign of meningitis. So management general principle, it actually requires interdisciplinary or multidisciplinary kind of effort. The family here are of, I would say, significant important. So try usually to use the family in the management, because your aim is to decrease the time for the healing and for the management. And usually the family will be of a great importance. And the management will be multifactorial approach is the most kind of successful, because multiple factors, as we've explained, for example, in the pathophysiology, contribute to delirium. Failure to diagnose and manage delirium, unfortunately, costly, life-threatening complication, loss of function. Okay, so when it comes to the keys to effective management, we should, first of all, identify and treat the reversible contributors. And that's need a good knowledge regarding the precipitating and the triggering factor. So optimize the medication and treat the infection. If the person is suffering from pain, you should tackle that. If the person is having dehydration or any kind of mineral disorder or those kind of things, you should deal with them. As we've mentioned also, if the person is having a problem with his insight, his eyesight, his hearing, you should also think about that. Maintain the behavioral control, behavioral and pharmacological intervention, anticipate and prevent complication, because while the person is having delirium, unfortunately, you might encounter another kind of a problem. For example, urinary incontinence, immobility, fall, pressure ulcer. So at the same time you are treating the person, think about the complication that might come as a result of delirium. And restore the function. So here we are talking about try to make the environment for the person or for the patient with the delirium as suitable as you can. So in fact, there is a recent research, I think, published in Medscape talking about that. There is a decrease by nearly 53% when they used an ear block to decrease the sound of the monitor. So all of those factors, you should encounter them when you are treating or managing the person. So the drug, we've just mentioned most of the kind of pathophysiology. So alcohol, benzodiazepine, anticonvulsant, antidepressant. We are talking here about the antidepressant that might cause anticholinergic activity, antihistamine, anti-Parkinsonism. So all of those medications. Behavioral problem provide social restraint, consider a sitter or allow family. Again, the family of a major importance when it comes to the management of the patient. If absolutely necessary, use haloperidol. So this is regarding the dose of haloperidol. And then regarding the rehabilitation, use oriental stimuli, for example, clock, calendar. This is just part of the environment. We've just talked about it. Use eyeglasses, hearing aids, those kind of manner. Mobilize the patient as soon as possible. Ensure adequate intake of nutrition fluid by hand feeding if necessary. And try to educate and support the patient and again, the family. So the best management is prevention by far. So it's always a good idea, especially in the elderly population, to try your best to decrease the risk factor. In summary, delirium is common and associated with substantial morbidity for the older people. Delirium can be diagnosed with a high sensitivity and specificity using the CAM. A thorough history, physical examination, focused lab, because we don't want to request each and every kind of test to lead to underlying causes of delirium. A careful medication review is mandatory. This is very important. Discontinue any likely to contribute delirium if possible. Managing delirium involving treating the primary disease, avoiding complication, managing behavioral problem, providing rehabilitation. The best treatment for delirium is prevention. So quick cases. Hopefully I didn't go beyond the time. So you can read the cases. The first case is talking about a 72-year-old man is evaluated because of a nurse are concerned about his agitation, which increased markedly in the evening. He underwent emergency hip replacement 3 days ago after he fell and fractured his hip. He requires antipsychotic agent to control his agitation. At night, he yells, "Help me," constantly, and is determined to get out of bed alone and walk. In the year before his fall, he had stopped working and driving. The reasons are unclear. The patient history includes hypertension, benign prostatic hyperplasia, osteoarthritis. There is no history of dementia. On examination, he appears confused and is disoriented to place and time. He has some pain with hip movement. Neurological findings are non-focal. The question, which of the following is the most established, which of the following is the most helpful in establishing the diagnosis of delirium? So feel free to write your answer in the chatting box. I'll give you 2 seconds, 30 seconds, maybe. Lovely. So many of the fellows mentioned A had an answer. I'll read the question again. Which of the following is the most helpful in establishing the diagnosis of delirium? So here we are talking about the diagnosis. We're not talking about the causes. So the answer will be C, perform the digit span memory test. So the case number 2, an 89-year-old man admitted to the nursing home for rehabilitation after being hospitalized for pneumonia. He's anxious and fidgety. He's widowed and lives in the community. History include hypertension, the same kind of things. Benign prostatic hyperplasia, major depression, chronic pain, medication on transfer to the nursing home include metoprolol, oxybutynin, paroxetine, acetaminophen with codeine, as we call it here, solbudin, I believe, and amitriptyline. So which of the following medication is least likely to contribute to delirium? Again, just for 5 seconds. Lovely. E. Yeah, I agree. The answer is E. All of the others will have some anticholinergic activity. And the last case, a 90-year-old man is brought to the emergency department by his family because he has had an abrupt change in behavior. The patient moved into his daughter and son-in-law's house a few months ago because he was no longer able to manage living alone. A few days ago, he became aggressive and angry, and he hits his son-in-law for no apparent reason. He has also become incontinent in the last few days. He has multiple bruises for which his family suspect from falling. Patient's history include moderate dementia and benign prostatic hyperplasia. His blood pressure as follows. He is uncooperative with the neurological examination, but appear to be normal. So which of the following is the most appropriate next step? Now here we are talking about a list of investigation. What do you think is the most appropriate? Lovely. And the answer is the basic metabolic panel. So thank you. This is the acknowledgement, mainly the American Geriatric Society, BMG, and up to date. Thank you, everyone. If you do have a question, please feel free to add.
Thank you so much, Dr. Hassan and Dr. Sulafa, for both your presentations, which were very excellent and concise and to the point, and I think it will be helpful for all fellows. Thank you so much. Any questions?
Thank you, Dr. Nader.
Thank you so much, Dr. Nader, and great presentation, Dr. Hassan.
Thank you, Sulafa. You too.
Thank you.
So if there is no question, then we can move to the third agenda. So Dr. Lubaba, when you're free, please go on. Thank you.
It's very beneficial that we do critical appraisal every meeting for a topic or an article. My connection is unstable. Are you guys hearing me?
Yes,
Yeah.
Lubaba. Now we hear it.
Yes.
Okay, so I just want to go over the critical appraisal process. I believe Sulafa presented about that a few weeks ago. It's gonna here. I found that's really beneficial, and as I mentioned before, many of the residents reach out about the critical appraisal because it's part of the training that they are getting and some of the process that they've been trained of. So the critical appraisal is basically how we evaluate articles and studies, research, and find out about the trustworthiness of the study and how we can apply that while we are practicing. One of this checklist we can say, or a tool that is used is called CASP, abbreviation for Critical Appraisal Skills Program. It's a kind of checklist, and there is available checklist for each study, depending on the type of the study, the checklist. Today, I'm going to go over the randomized clinical trials, and they have one. Just let me share the screen. Okay. You guys see my screen?
Yes.
Okay, thank you. Let me just move. Okay, so this is the checklist that I'm talking about. The Critical Appraisal Skills Program. So it's a checklist, as I mentioned, there is for the other different kind of studies and researches. For example, this is for the randomized controlled trials. And it has like 11 kind of questions that you will use to assess the article or the study that you're going to evaluate. And mainly we are looking for the validity of the study and the trustworthiness, as I mentioned, and how we can apply that in our practice. So some of these questions looks into the validity, other looks into the trustworthiness, and some looks into the relevance and applicability of the question. So the article that I prepared for today, and I found that usually most of the answers you can find them actually in the abstract if you focus, but you still need to read over the article itself. But maybe from initially, if you look at the abstract, might find out if you're gonna continue reading the article, whether it is beneficial for your practice or not. So this is a recently published article in JAMA. It's effect of subcutaneous casirivimab and imidivimab antibody combination versus placebo on development of symptomatic COVID-19 in early asymptomatic SARS-CoV-2 infection. It's a randomized clinical trial, as I mentioned. So the objective, I'm gonna read just through the abstract, and then we can go back to the questions. And here, last year, we used to have like two presenters for the critical appraisal part, where one will read the questions and the other one will go over the answer from the article. So here it's the objective of this article is to evaluate the effect of combination subcutaneous casirivimab and imidivimab on progression from early asymptomatic SARS-CoV-2 infection to symptomatic COVID-19. The design and setting and participant were randomized, double-blind, placebo-controlled phase 3 trial of close household contacts of SARS-CoV-2 infected in this case at 112 sites in the US, Romania, and Moldova, enrolled from July 13th of 2020 to January 20th of 2021, ended at March. So asymptomatic individuals were age 12 and above, were eligible if identified within 96 hours of index case positive test collection. result from 314 individuals positive on SARS-CoV-2 reverse transcriptase or PCR tests were reported. So the intervention were randomized. Individuals were randomized 1-to-1 to receive 1 dose of subcutaneous casirivimab and imidivimab, 1200 milligram for the 158 of these participants, and the other one received placebo. The main outcome and measures were the primary endpoint was the proportion of seronegative participants who developed symptomatic COVID-19 during the 28-day efficacy assessment period. So the researchers identified the 28-day efficacy assessment period where they followed the participant weekly to find out whether they will they will develop symptoms or not. The key secondary efficacy endpoints were the number of weeks of symptomatic SARS-CoV-2 infection and number of weeks of high viral load. So the secondary outcome were two identified in this study as well. So, and here they describe the results and they found out that 40 or 56% of the participants were 51.6 were women, and these 9.7 completed the efficacy assessment period. So the loss were, I think, 3 participants. They did not complete the trial. 204 were asymptomatic and seronegative at baseline and included in the primary efficacy analysis. So basically, most of the participants were included at the end of the or at the analysis and the reporting of the outcome. So the conclusion and the relevance among asymptomatic SARS-CoV-2 PCR positive individuals living with an infected household contact, treatment with subcutaneous casirivimab and imidivimab antibody combination versus placebo significantly reduced the incidence of symptomatic COVID-19 over 28 days, which is the efficacy period that they calculated. Over here, they mentioned details about the results and confidence interval and p-values to the extent that we can evaluate and see if this kind of relevant and applicable in the situation. Excuse me. So the first question is, usually focus is on what we call PICO, which is, did the trial address a clearly focused issue? This is, PICO is under abbreviation for the population, the intervention, the outcome, and the participant or the comparator, which we, in this case, we have the placebo group. So this, based on the abstract I just skimmed over, is like they did identify the population, and the intervention was the 2 monoclonal antibodies. In addition to that, they mentioned that there's 2 groups, a placebo group, and they talk about the end primary outcome and secondary outcome as well. So for this question, I believe that the study covered it very well, and they mentioned all of these things that we should look at in a study. So the answer for this be yes, unless you guys feel like there is something missing or they want to know something else. I'm trying to make this as much interactive as possible if you are guys following me. If you have any comment, please jump on and let me know. Am I clear so far?
Yes, Lubaba, thank
you.
Okay, thank you. Okay, so the second question is what the assignment of patients to treatments randomized. So this is clearly from the title and what they mention in the study itself. It is double-blinded randomized controlled trial. So as they mentioned, that randomized controlled trial as one of the gold standard kind of researches that we depend on. So in this area, we can say with full mouth that say yes. So it was carried randomized, and they mentioned that in the study. The third question is where all of the patients who entered the trial properly accounted for at its conclusion. So I went over the results section here, and they did mention that how they lost 3 of the participants Okay, so between July 13, 2020 and January 28, 21, total of 314 household contacts were confirmed, and they were positive at baseline based on central lab PCR test. 156 study participants received placebo, 155 received subcutaneous casirivimab and imidivimab at 1200 milligram, as I mentioned. They mentioned here the percentage of those who develop symptoms on the group of the treatment and the group of the placebo, and they found that it's 27% were seronegative and 23 had undetermined status, and there is 66% were seronegative, were 66%, sorry, 27 were seropositive, and 23 had undetermined status. So the undetermined status actually included those they lost the follow-up, or they were excluded from the study. So I believe that this question is an answer is yes. They mention everything in the conclusion and the results part for this study. Accounted for all of the participants. So the fourth question is, were patients, health workers, and study personnel blind to treatment? So again, they mentioned that it's randomized, double-blinded for both in terms of the intervention, whether they receive placebo or not. They are randomized, and the healthcare personnel were blinded as well. However, the contact were the household was. So the randomization, the blinding here, they mentioned that the household, for example, if the household there is 5 or 6 were contact of a positive patient, so they are blinded as well. So the 6, we don't know who received the placebo and who received the intervention itself. So within the household is randomized, within the healthcare worker is randomized, and within the participant themselves is randomized. So it is very, we can say yes in this question as well. So were the groups similar at the start of the trial? So this kind of little bit utilized judgment in this case, because basically all of the participants were contact of COVID patients, confirmed COVID patient. They were either seronegative or seropositive at the baseline. However, where all of them were similar at the start of the trial, I believe it is not, or we cannot tell, since it is done in different sites. This is my opinion, 112 sites across US and Romania and Moldova, I believe. And they mentioned that most of these sites are in US. So I think at the start of the trial, we cannot say those are similar. This is from my point of view. As age, sex, and social classes. So age, they mentioned that they are 12 or older. They mentioned that 56, we can say 50-50 female-male ratio. However, the social class and that we cannot say, yes, they were all similar at the beginning of the trial, since they were in different sites and different locations in the world. Number 6 is, aside from the experimental intervention, where the groups treated equally. So they mentioned that they tried to make all of the restrictions and all of the study criteria similar in all of the sites. So I believe that we can say yes in this area. It's experimental intervention. They did the blinding, they did the allocation, and all of these trying to reduce as much as possible the biases. So I would say they did the best they can do. They mentioned in that study that too. So for you, I'm sorry, I'm trying to go over all of the questions just to give the general idea about how we can do this in the future. But in details, they mentioned that all of these kind of criteria, so it would be easier if we all read the article. But for the sake of time, I don't want to go back and forth for all of these points, but this is what I came across. Number 7, they say how large was the treatment effect? So, and they provide some hints that allow you to go back and answer this question. What outcomes were measured, and is the primary outcome clearly specified, and what results were found for each outcome? The outcome were measured. So they were looking for the development of the symptoms, doing lab tests and see how much of those converted from actually seronegative to seropositive, and whether the seropositive one developed symptoms or not, and comparing that with the placebo and the intervention. They mentioned that the primary outcome was clearly specified, and the secondary outcomes were clearly specified as well. And all of these were reported. So I would say this is a yes as well. How precise was the statement or the estimate of the treatment effect? So this will be like more kind of statistical calculation. So they provided how they compared these findings, and they provided confidence interval, p-values, odd ratios, and all of these calculations. And however, the only thing that I would say that the confidence interval kind of little bit wide. So this will affect the precision of the study. But other than that, all of these were explained in the study. Number 9 is, can the results be applied to the local population or in your population or in your context? So this is kind of based of clinical judgment, and how is the generability of this study. And this is the third part that we are looking for when we are doing critical appraisal, whether it's relevant to the current practice and whether it's applicable or not. And this is usually, you can go back on the study and look if there is limitation that mentioned by the authors. In this case, since it is, yes, it is 112, it looks like it's a multi-centers. And but most of these centers were in the US and Romania and Moldova, no other part of the world. They tried to reach out for non-white participants, but the participants were mostly white on these or Caucasian, if we are not trying to use an appropriate kind of phrases. Anyway, all of these actually will, we can consider when we are talking about how to apply and generalize this kind of study. A lot of limitations were mentioned by the author, so I don't think it is applicable everywhere. In addition to that, the reporting of these results were out before the widespread, actually this was conducted before the widespread of vaccines and the widespread of the new variant of COVID, for example, Delta, Omicron, and all of these. And even that mentioned in the study that some of the newly known facts about COVID and involvement of COVID and the benefit of vaccine were not there when the report was analyzed and all of these. So talking about that, I think it is not applicable everywhere at this point. Number 10, were all clinical important outcomes considered? I believe they did an excellent job in providing other clinical outcomes consideration for example, hospital admission on the treatment arm and the placebo arm, in addition to ER visits. They mentioned that, and they mentioned that actually the combination of the two monoclonal antibodies prevented ED visits and hospitalization, where 6 in the placebo were having ED visit and ended up being hospitalized, I think 1 or 2. So I think, yeah, they mentioned good and relevant clinical importance outcomes in this study. The number 11, the last question is, are the benefits worth the harms and costs? So I think this is subjective kind of assessment you will think about. From my opinion, that COVID is a new disease, and I think every effort to understand how the process and how to prevent and how to treat is worth the effort and the harm. Gladly no harms, but the cost, I think it's worth the cost to do anything regarding COVID to understand it. This is just like a try from me for us to resume kind of critical appraisal for its importance. And thank you for listening. And if you have any question, I'm happy to answer. Thank you.
Thank you, Lubaba. Dr. Nader, if you do have any.
Thank you so much, Dr. Lubaba. That's really excellent and good presentation, and also demonstration about the importance of this tool. So basically, when you enter residency, inshallah, you will be assigned some articles to discuss either in some sort of meetings between residents or taking fellows. It will be assigned for any one of the group students, sometimes students, sometimes residents or fellows. And your job basically is to dissect the article that you want to present. So you cannot present the article summary of what they did, and then you want to identify if this is a good article, if it is useful, if it is applicable to the community of the population that you serve. So this one tool presented by Lubaba, I think it's very useful tool. We used it last year, and we can use it for this group as well. And hopefully we can practice and see if we can use it to assess and analyze the articles that we read and make a comment that is it useful for me, for my patients, or not. And at the same time, I think it will help you when you want to write for yourself or for your team, when you want to submit a manuscript, your analysis for your the pieces that you want to write. I think it will make sense because you will have some critics from the editors or the reviewers in this journal when you submit your article or manuscript. So I think it's going to be useful in that sense also. Thank you so much.
You're welcome. Thank you. I can share the documents for the CASP for all of these through our website and WhatsApp, and we can utilize them in the upcoming meetings.
Sounds good.
Thank you, Lubaba. Thank you, Dr. Nader. Now we can move to the fourth part of our meeting today. So any update in the projects? Please feel free if you do have any update.
I don't see Ala in the attendance yet, but she and her group submitted the abstract about non-pharmacological approach for intervention in nursing homes during COVID to pain conference. So they sent that abstract. Hopefully we'll hear good news. The second update, I think maybe some of you, she is her team are working on the poster for the next conference, and I think so she's sending the PowerPoint for the poster, and I think some of you are working on the other poster. Correct me at the national, you know, about the activity in the nursing home also during COVID. If your team are working on the poster also.
Yeah, I'm one of the team. So regarding the poster, I think we are on the last stage. So the poster is almost ready. There is just 13 things now we are working on. So I think it was a good week. She did many jobs, and then now just we are working on the audio kind of files, and hopefully soon we're gonna finish it.
Excellent. So it's gonna be a visual one, which is a good one. Do you know how many minutes allowed?
I'm not sure.
Usually 3 or 5 minutes. Lubaba, remember last year or something?
I think for the abstract, we're 10 for AMDA. And but the presentation, I think it would be the audio part, because it's a three minutes kind of audio maximum.
Sounds good.
I think, yeah, it's for audio, it's 3 to 5 minutes for 2 presenter maximum, something like that. Thank you.
Regarding the long COVID project, we will hold our next meeting tomorrow, inshallah, to discuss the next steps. But so far, people are enthusiastic and preparing. Give you. Thank you.
Any other updates? Any other ideas for projects or? So I have a couple of ideas. One of them is YouTube. If we can analyze some of the number of YouTube videos regarding COVID in older adults, if we see how many are targeting this group, and if we can analyze them to see if there is misinformation or good information in these videos. So we can limit that to just the English language, and maybe we can limit it by time, certain period of time, similar to the article we present, and see if we need to address this, and maybe we should recommend more education material to be uploaded in YouTube, as it's a good platform for education. What do you think? And if interested, let me know. The other update I want to share with you is at the department here, we have some projects. One of them is talking about the use of different devices like a tablet or phones or machines that have like computer and attached devices in nursing homes during the COVID, and the perception of the staff, the nursing staff. What do they think about using these devices during the pandemic? And do they think it's helpful, it's not helpful? And what things did they use it for? Some use it for clinical, like physician can access remotely, and some used it during the COVID for social, like the patient may be in contact with their families or friends remotely. So we collected some, it's like a focus group discussion. So we collected some feedback from nursing staff, social worker, activity staff in 2 different nursing homes. And we are in the process of analyzing this to put them into teams, kind of, and then writing a manuscript about this. So anyone interested in this project, also let me know. We can share some of the data so that I can help with the analysis and maybe help with writing the manuscript. The third point I want to share is we have a different project where 4 of the attendants here, they have some presentations similar to what Dr. Hassan just presented about delirium. These presentations will be focusing on primary care issues, mostly in rural areas, but it can be applied in urban areas as well. So we have about maybe 20-something topics. I think we can select a couple of topics for you guys, and then we will ask one or a couple of these attendants to present it to you. It can be live, similar to what Hassan presented today, like 30 minutes to 1 hour session. And then you can ask questions. This will be an educational opportunity for you, as well as, if you want to give feedback for these attendings. So I can share with you the list of topics, and you can select which one interested for you, but you are interested in this, if it makes sense, and then we can ask the presenter or the attending to present in their time. If it's good time for you, maybe you can attend. If you are busy and you are working or time is not good for you, maybe you can just view the recorded material, and then you can comment on that material. We will assess later. So I'm going to share with you a list of topics for presentations, and let me know, select a couple of them or whatever you like. Okay. Anything else? We can switch to updates about your views or any updates about the program's presidency fellowships.
Yes, yeah, so before we go to that, that's actually a great idea. Send us the list and we can select the subject that we need a presentation on. And I have a question regarding the recording for example, grand rounds and the neurology grand rounds as well. Do you have access for them? I usually sometimes miss to attending, and I found it really very beneficial. For example, yesterday's subject in neurology was really interesting, and I came in at the end, but I was not able to follow. I'm just wondering if we can have the recordings for that too.
Okay. Sometimes I ask the coordinator, and sometimes she has access to it's all of them, I think, recorded.
Yes.
So we can ask them to see which one you missed. We can ask them for the recording. I did ask them in the past. Yeah, I do.
Thank you.
And for those who have the time to attend, I think they are useful. And you can mention them during your interviews, or you can mention them in your resume or application that you are attending interviews in grand rounds or grand rounds. It will help you keep up to date as far as your CV, and hopefully help you with your interview. Thanks. All right. Perhaps we can set up the agenda for next week. If you have any comments or any questions, let me know. Okay. So I can share with you. Perhaps next week your team can present some, or if Tina available, she can be. Someone else is interested, they can be the meeting. And then I just put here some names. You can agree or disagree, or you can add your name, and you can just go to the pen here and edit your draft. For instance, doesn't want to present with someone else, they can just put their name here. And the same with Sulafa. If you have time to some of the analysis next week as far as SPSS. Maybe you can do that, or maybe someone else can put their names and put Hassan soon or someone for discussion about the critical appraisal. So in the app, if you want to do that, that might be an option for you guys. Any other topics or things that you want me to discuss or to present?
I think it's sufficient time-wise and subject-wise, in my opinion.
Thank you. Sulafa,
Yes, hello, sorry.
hello.
My internet was disconnected, so I go and come back.
So will you be available? Will you be willing to share, present the same way, like SPSS to continue with some of the
Sure,
analysis?
sure.
Okay.
Yeah.
So I think I put back that. Dr. Varga, are you able to attend next meeting and present? If not, maybe someone else can jump and let us know.
I would like to present the respiratory diseases.
Okay, we can do that. Someone else can jump as far as critical appraisal. I put Anna saying, so maybe you can let me know if you are able or not able to.
I think I will contact with my team and then get back to you. I'm still recovering from COVID.
Oh, sorry, so hopefully you feel better. So I will remove you, but
Yeah.
maybe Dr. Samah and Anna can find someone else for the appraisal. Hopefully you feel better. So,
Thank you. Yeah. Mhm.
anyone of the yellow team can help, or if not, maybe Lubaba, if you are available next week, maybe you can go over it with Dr. Samah or someone.
Yes.
Just, so this is how we can do the setting the agenda for coming Zoom meeting, and if anyone may have any reason not to attend or some family issues, then between you and the team, maybe you can ask someone else to cover you for your topic. So at least we know it's covered and people are ready for the meeting. So it makes sense. So. And you can use the app to edit that as well, just so that that can be updated as well. You can discuss in your WhatsApp group, but if you can update the app, I'll be following as well. Thank you. So for me, I'm gonna send you a list of the presentations of the topics for you. Whenever you have a time, look at the list. Let me know which topic or presentation interests you. I will talk to the presenters here, and then we will find some date and time period so that they can present it. If you are available, you can attend. If not, we will send you the link for the recorded material, and you can come again. All right, still I am not sure who is the leader for the orange team. If you can let me know. that would be great. Dr. Samah, I put you on, and maybe you can do
Okay,
you,
Dr. Nader.
you want to be the leader, or you can let me know who the orange team. That would be great.
I'm in the yellow team.
Oh, in the, yeah, okay, so maybe
Yeah, sorry about that.
That's all right.
That's
The
okay.
other Samah.
Dr. Samah, sorry.
Yeah, that's okay. So someone can let me know. Okay. Anything else you want to discuss? Anything else you want to share? If not, we can end the meeting. And I'd like to thank you all. And thank you, Dr. Sulafa, Dr. Lubaba, and Dr. Hassan for your presentation. Thank you all for attending. Good luck. Hopefully you'll be okay for the next time. Assalamu alaikum. Have a wonderful
Thank
day.
you so much.
Thank you.
Ma'as
Thank you.
salam.
Assalamu alaikum.
Thank you so much, sir.
Dr. Nader.
Assalamu alaikum.
Thank you.
Thank you.
Thank you so much.
Thank you. Bye.